So welcome to the latest in the series of ECIST podcasts. I'm delighted to be joined today by colleagues from Leeds Teaching Hospitals NHS Trust. And we're talking today about escalation, site management, and particularly how IT can help support those functions. So let's get straight into this. And Sarah, could you briefly describe your organisation?
So Leeds Teaching Hospitals is a large acute provider based in Yorkshire, in the north of England. From an emergency department perspective, we see over 250,000 acute presentations per annum, spread across 3 EDs, which are based at 2 separate sites. So we have 2 adult emergency departments and a paediatric ED. We are also the region's major trauma centre. And we're also a tertiary referral unit for multiple subspecialties across both of our sites, both for paediatric patients as part of the Leeds Children's Hospital, but also for adult patients across a number of specialties. So we're a very hefty, quite large organisation, but spread across the city.
Thanks, Sarah. So just moving over to you, Sue, the Leeds is a large and complex organisation. What are the challenges in gathering live data for the site meetings and ensuring an operational oversight of the whole organisation?
So Leeds currently doesn't have a live bed state, so we really rely on patient flow coordinators giving us appropriate and timely information to gather that oversight of the site and our occupancy. We also use the PPM system to check on site online that we can look at where empty beds are, just to double check what PFCs are telling us. We dial into Microsoft Teams meetings where the PFCs will update us on their clinical service units and bed availability, their elective and acute capacity, what's coming through on the unplanned care and the planned care. And we've also just instated on a temporary measure a team called the After Hours Response Team, who are currently going round out of hours just to sort of sense check what the CSUs are telling us is their bed state and what we have available on site.
Thanks, Sue. And just for clarity, when you say PPM, is that your organisation's electronic patient record and information repository?
It is, yes.
Okay, thank you. So, Stuart, how does IT and how can IT support the provision of information for the Ops Centre?
I think there are a couple of different solutions that we can look at there. I think one of the key factors is going to be live bed state when that eventually becomes live, taking away the need for manual tracking of where the patients are as they move through with RFID wristbands to track as to where they're still on the ward, which bays they're in. And that will be a real step forward. I think alongside that, we use a system called Chembooks, which gives you an organisational overview of all the different current assessment areas within the organisation, with sit reps that are filled in on a specified timescale, which tell you the key KPIs for those assessment areas. So it includes the emergency departments, same-day emergency care areas, multi-specialty assessment areas coming online, along with gynae assessments and critical care, surgical assessments, etc. And for each of those, they've all really got similar key KPIs, which are generally how many patients have they got on there at the moment, how many have they got waiting to go to beds, and what's the sort of wait time to see a clinician while you're on there. So using that system, we can see in each area what the current capacity and demand pressures are. And that alongside our sort of departmental operating reports gives us a clear idea as to what's going on in each area and what capacity we've got across the organisation. A lot of that data can be automated in terms of how the feeds come into Chembooks. So the ED data, for instance, comes directly from Symphony, our patient tracking system from the data warehouse, So you just click on SitRep and it can tell you immediately how many patients you've got in the department, how many are in resus, how many have you got waiting for beds. So I think IT will systems that are brought into the organisation and gradually developed and making sure that they integrate with each other will eventually replace the need to having to walk around and manually check all the different wards to check where numbers of patients are and where might be there's some free beds.
Thanks. So one of the things that, of course, arises from this information coming in is the need to respond to service pressures. So, Sarah, what are the challenges that you find in communicating escalations and ensuring that there's an appropriate response to that?
So I think if we go back just a number of sort of steps really, prior to using Chembooks as our primary mode of communication, not just ourselves within the CSU, so the management team, but also from the wider organisation, we used a combination of methods, none of which were ideal. So we used a combination of email, text messaging and phone calls to specific points in that communication chain. So there'll be messaging from the nursing hierarchy through to the nursing charge. There'll be messaging through from our bronze commander or the person on point within the clinical service unit down to the consultant on the shop floor. But all of that was breaking the teams away from providing care within our units. And also it was very, very labour intensive. And there was no record of that communication having happened or occurred, and there was nowhere to then consult. So what we're now utilising is a system by which you can have that two-way communication using Chembooks. So we can use that as an escalation tool. So it's not just a repository of how the departments are and a sense check and a barometer, but also enables us to communicate really clearly and really transparently. So for example, it might well be that Sue will hold a bed meeting at 1 o'clock, and the information from that 1 o'clock bed meeting will be fed into Chembooks by our CSU, and that information is then freely visible to the whole of our clinical team. So everybody knows where the organisation is. And equally, we can use it as an action log. So it may well be that a problem within the emergency department is escalated via Chembooks. We can assign that to a specific individual, and then there can be two-way communication using that system in a really logged and transparent way so that we can see who's actioned that and what action has been taken. So there's no duplication, there's no lost in translation, and there's no Chinese whispers. It's all there and it's clear, it's documented, and we can see who's done what when in response, but also allows us to be incredibly proactive to solve a problem before it's become a problem. So I think we're using IT in a much more dynamic way that doesn't involve individual accounts, phone numbers, text messaging, and email addresses.
Thank you. And Stu, can you describe to us a little bit about how Chembooks can takes an active role in pushing out escalations?
Yeah, so when you implement Chembooks, as we were talking about, each area might have some KPIs. So we talk about the number of patients in department, for instance, and you might say that when we get over 80 patients in the department, that is purple. So we've got green, red, amber and purple, opal scoring. And then within Chembooks, you can build in fixed escalations that are generated whenever you click a purple, whenever you hit a purple KPI. So if we hit over 80 patients in the department at St James's, that turns the number of patients in departments purple. That generates an activate surge plan escalation card, which goes to the consultant in charge and the nurse in charge that they need to have activated surge 1. You can see that in the escalation engine. So you can track how often the escalations have been triggered and how often they've been actioned. And then you get an individual ticket for each escalation, so you can see when and who it's been completed by and what they did at what time to make that escalation happen. But that's for individual KPIs, but overall as well, if the organisation goes into silver command, for instance, where there might be a meeting at 4 o'clock in the evening with a plan then for the evening for further escalations to go out, that's now documented on Chembooks at the top of the organisation and allows increased visibility for everyone in the ED who doesn't necessarily need to be on that silver command call, but actually it's good to be able to see what's happening in the wider organisation to support flow through the ED. And by putting it on Chembooks rather than keeping it in small email circulation trails, actually it increases the visibility and increases the openness to what is being done to support the emergency department in difficult times.
Thanks, Stu. That's really interesting. So moving to a related area, the internal professional standards are in place in many organisations now. Sarah, can you describe to us how in Leeds the Trust's internal professional standards link in with both business as usual and also Escalation?
So I think you're absolutely right, Kevin. It would be no surprise to anyone listening that Leeds has its own set of internal professional standards that have grown and evolved over time. I think we've had a refresh into the beginning of 2022, sent out to all medical professionals and clinicians working within our organisation. But what we've also done is added a layer of accountability into that internal professional standards by utilising Chembooks as a logging tool. So what it allows us to do is to take specific internal professional standards. So, for example, one clear internal professional standards is that an inpatient team shouldn't utilise the emergency department to assess patients that don't require the resuscitation services. So needs to have a mechanism by which they can facilitate that patient review. So what we can then do is when that does not happen, and at times it doesn't, we're an organisation with a very high bed occupancy, sitting at around 99.5%, which makes it a challenge, is that we can document that in Chembooks in a really accountable way. So, you know, this patient arrived in the ED, they didn't need to be in an emergency department, there needs to be a better way. So we can then take that back to clinical teams to say, in the month of October, X number of your patients were advised to attend the emergency department. There must be a better way. So we can then work on pathways and processes in keeping with those internal professional standards, in keeping with the Trust's values in the Leeds way. So what that enables us to do is to work with that team to really transition their care. So, for example, we've worked with one of our clinical service units quite markedly in the last few months, to the point where last month they had no logs of that type with regards to that activity, because they've absolutely changed the way that they advise their patients to access care. And that means the patient goes to the right place at the right time and sees the right clinician. They're not sitting in ED. So I think it's just one way that we're utilising the IT systems to really change pathways for our patients, but also to make sure that we're really looking at those internal professional standards, and they are becoming business as usual. They are the normal way that we work, and everyone is expected to sit within that framework. So it's a way of holding our teams accountable to those internal professional standards, but in a really positive way.
I think on the back of that, Sarah, I think as you see, once you start to see those positive changes, you start to see positive feedback. Actually, well, that team that Sarah's mentioning there, they took 60 patients from the front desk, for instance, the other day, and you get positive reinforcement there of the right behaviours being done. Rather than just, it's not all negative, it can be positive as well, and we get, you know, there's at least a third to a half become positive remarks and comments that are kept on the specialty interactions logs there.
Thanks. So just to discuss the internal professional standards a little bit further, I've seen in my role with ECIST a whole variety of approaches to developing and implementing IPSs, from very much a top-down, the medical director demands that everybody do this, to ones that are built very much from the ground up. Can you tell us about the approach in Leeds?
I think we both talked about it, can't we, Stuart?
Yeah.
So I think they've grown very organically. So we did have a set of internal professional standards that really were based around the emergency department and the emergency care standard and response times. Actually, what they've evolved into with clinical input at all levels is rules of engagement in a way that is in every sector of our organisation. So it's not just about the emergency department and unplanned care, but there's also internal professional standards looking at planned care, looking at response times. But actually, they've evolved and grown, but they are clinically owned, and they're owned by our clinicians. Initially signed off and developed by our clinical directors as a group, led by our operations centre clinical director, but then signed off by our executive team. So here is a set of standards that are owned by our clinicians and are driven by the clinical directors to hold our teams accountable and responsive. Ultimately, the medical director may step in at times, but actually it doesn't get to that point because it's owned by the clinicians themselves. So they don't need policing per se, because the clinicians are owning this and morphing them and changing them, moving them forward. Is it perfection? Absolutely not. Do we still have a long way to go? Yes, but it's evolving and it's organic and it's owned by the clinicians.
And I think to add to that, we're providing feedback on a regular basis for the things that do work and the things that don't work. And I think they've evolved from the original sort of 10 steps, which were about emergency care and about initial patient flow, to including service level agreements around diagnostics and around imaging and around turnaround times, all focused around delivering excellent patient care in a really timely manner that supports flow through the whole organisation, not just from the emergency department out, but actually is part of the discharge work, and really do sit in line with the focused model that ECIST provide around how the site should be run and operated. And as part of that, from the ops centre point of view, we're doing sort of roadshows going around all the different specialties, highlighting these to their initially to consultants, but also to registrar teams, those who are engaging with the emergency department on a daily basis, taking referrals and trying to highlight where their responsibility is within that, and also that we do pick up and we do record when incidents happen and when it doesn't go quite to plan. But these will no longer just be anecdotes that, oh, once something happened. Actually, it will be, last month this happened twice and this happened also 2 months ago as well. So come on, there's something we need to try and sort out here. Part of the idea there is that by recording that on Chem books and keeping a track of these specialty interaction logs, we can take away any of the friction that happens on the shop floor and actually take that back a step so that it's happening where there might be disagreements about certain pathways. That's taken away from where care is being delivered. Naturally, we try and sort that out on a separate meetings in a different place, so actually our clinical teams can work relatively smoothly in line with the IPS standards.
It's also a dynamic two-way process. So very much the sort of 10 steps that Stuart referred to was very much the emergency department expects the organisation to do these things. The internal professional standards is very much a two-way phenomenon. So the emergency department can expect our organisation to respond in this way, but equally the organisation is asking the emergency departments, the assessment areas, the inpatient wards, the clinical teams to respond in this way. So it's very much a bilateral dynamic process. It's not just about the emergency department.
So just lastly, we've spoken to you all of you in your leadership roles. How does the Leeds approach to managing escalation work for you in your day-to-day job?
From my point of view, as an emergency department consultant on a shift on a Monday evening when things get busy, it really is useful for me to be able to see what has been decided at Silver and to have visibility of that and to know that those actions are taking place. For me to do a sit rep that says we've got over 80 patients in the department at St James's open surge area. Okay, well, when we first started doing that, we had overlap between when our SDEC areas were open and when they weren't, but actually now it's a case of knowing when I can move patients into the surge area, where are our surge areas, making sure I do that and that I can feed back and I can look back and know how many times that's being activated or not, making sure that I can record in my shift handovers which escalations have been done, which escalations have made a difference, and know that if we're going into our exceptional surge area plan, that has been done, which are the triggers that activate that. Know that may not necessarily be my decision as a consultant, but I need to have spoken to the clinical site management team. That's my job in that part. If we have, say, over 30 patients TCI'd, I need to be speaking to someone about that. Are we going into ESA? What's the impact of that and what bed availability is there? So to me, it makes the escalation plan real. I understand what my role is within it, and I know the bits that I need to do to facilitate that.
Thank you. Sue, have you got any comments?
Yeah, I think from a site management point of view, our escalation plan varies massively from an in-hours to an out-of-hours plan. So in-hours we're very much using the Chief Operating Officer's team and the daily person that's on for escalation. So we will liaise with them quite a lot. We also use Symphony in hours to escalate individual patients, and we'll put an escalation in there so that the ED team can see in hours if there's anything the site management team are doing specifically for a patient. And then out of hours, our escalation, obviously we have an on-call team that we utilise, but we will use Chem books where we can put things in and the wider organisation can see what the site manager's done for going into surge, how we've managed to staff that with nursing, where we've pulled nurses from to enable safe staffing. So all those things can go into Chem books, and I feel like the CSN team have got a really clear plan of where we need to document things and how and whom we need to escalate things to.
I think for me, Kevin, it's a bit more simple than that, if I'm really honest. What it does is it cuts out the endless and unnecessary phone calls. It's a practical thing. It's taking out the non-value added steps in my clinical day when I'm trying to deliver care to our patients. I'm trying to supervise our trainees. I'm trying to ensure the department is running smoothly. What I'm not doing is spending half of that shift on the phone, checking X has been done, Y's been done, who's doing this, why has that not happened? Because what I can do is I can open up Chem books and I can see that in front of me. So I can get an update in 30 seconds flat, which previously would have taken 4 or 5 phone calls. I'd have then had to wait for a phone call back. I'm not doing any of that. So actually what it's doing is it's releasing my time back into the department to do the job I'm actually being paid to do, which is to manage the department and the patients and the staff in front of me, not be constantly on the end of a phone or having to go into my email account to find out what's going on and what's happening. So it's a really practical solution to not being dragged away from your core business and having one repository of information. So I'm not distracted. I can carry on with my day as usual, and that for me is its simplicity, but also its strength.
Thank you. So I think if I was to summarise that, it sounds as though you've developed a process and have supporting IT that allows you to get on with your job. So this is something that works for the organisation, it works for individual services, works for the professionals, and most of all, it's therefore working for patients. So thank you very much for your time this morning. It's been a really interesting chat with you, and we hope that we'll see many of you are watching at our next podcast, which will be out in the near future. Thank you.